give it just another minute and then we'll get started with today's webinar.
Laura, did you start the recording?
Yes, it's going. We're good.
Great, thank you.
All right. Well, happy hot Thursday, everybody. Good morning. My name is Laura Collins. I'm here with Karen Hill and Deb Peartree from HMA representing the Alliance to talk today about transitions of care in ECM in particular. So we're excited to be here with you. And why don't we just start with some housekeeping?
Well, wait a minute. We also have Liliana from Monterey Public Health with
Absolutely.
us today. Yeah.
Thank you, Karen. Welcoming Liliana Rodriguez from Monterey Public Health. Yes, who will be joining us today.
Yeah.
Quickly, next slide, and just touching on some housekeeping. We are recording today's webinar, and we will also be distributing both the recording and a copy of the presentation afterwards. Please chat the host if you're having technical difficulties today. And we do have an evaluation at the end that we'll just put in the chat for you to click on the link. We love hearing your feedback. In today's evaluation, we have a couple extra questions for more input, in particular around the learning session and next learning session, and also in terms of sharing each other's contact information. Sounds like people want to get connected. Let's go to the next slide, and I want to just pause to see if there's any messages from Jessica or Christine, if you're on from the Alliance. Any notes, any comments today or messages for the group?
Hi.
Oh, go ahead.
Nope. Go for it. Go for it.
Good morning, everyone. Thank you, Laura. And I just had a quick request because we are looking at which organizations we have joining the call. So if you could, on your Zoom, just right click on your name there on the ellipsis and add next to your name your organization. If you had a minute, that'd be really helpful. And go ahead, Jessica.
I was just going to mention, excuse me, for those of you in Santa Cruz, Monterey County, I'm sorry, we'll be sending some information out about smart referrals, that closed loop referral system. So I just wanted to give you guys and your team a heads up that some information will be coming out about that soon. And I think that's it.
Good to hear from you. All right, let's go to the next slide. And there you see Karen and I in our mugs. We're again to be here with you today, and again also have our guest speaker, Liliana Rodriguez from Monterey Public Health, who we'll be hearing about near the end of today's presentation, tying it all together in terms of transitions of care work. Let's go to the next slide and just touch quickly on the agenda. So today, like we've done in the past, we'll be talking about transitions of care using that what, how, and why model, that golden circle that really helps us structure the conversation. We typically start with the why, but today we're going to start with the what, and then we'll move to the how, and then we'll finish with grounding ourselves in the why behind transitions of care, or TOC. You'll hear TOC a lot today. So starting with the what of transitions of care, including comprehensive transitional care in ECM. That's the term that the state uses for this work. And then we're going to hear from Liliana from Monterey Public Health, who will talk about a different transition of care and their strategies to bring success to that. And then we'll also cover best practices, including talking about virtual TOC work. And then again, ending with the why today with Karen. All right, so let's quickly go to the next slide and talk about the learning objectives. So today we're hoping that you walk away with an understanding of what comprehensive transitional care is in the ECM. I'll be discussing how important engaging individuals during transitions of care are, and so will Karen, and how key that is in improving both clinical and social outcomes. And finally, we hope you walk away with a better understanding of best practices for TOC work, including that virtual work that we've all become accustomed to using thanks to the pandemic. All right, next slide. So here we go. Cynic's golden circle. We're starting with the what, the outer circle. Everyone knows it. And if you see, we'll keep crawling our way in through the how and the why. So here we go. Let's go to the next slide and start with the what. So what are transitions of care in healthcare? A transition of care is essentially when someone's transitioning from one level of care or one setting to another. It's essentially a point of vulnerability, or a way of putting it, I like to put it as an opportunity to support success during an individual's transition. So here's a list of settings that someone may be transferring from or to. The most common transition of care, or TOC, that we talk about in this work is when someone's transferring from a hospital to home or to another facility. But there really is a broader definition. The most common transition of care, so that's the most common transition of care. But in fact, today when we hear from Monterey, they'll be talking about supporting someone's graduation from ECM as a transition in care to step down to a lower level of care. So just a snapshot of the slide here. Just a lot of different types of transitions or vulnerability points or opportunities for our clients or patients or members to go to and from. Let's go to the next slide. So still on the what today, as I mentioned, transitions of care are those vulnerable points in an individual's journey through the continuum of care. And these transitions get a lot of attention from the healthcare community because they're considered points where someone may fall through the cracks or decline in their condition if the transition is not handled smoothly with good communication throughout. So the Agency for Healthcare Research and Quality sums up the critical importance of communication between providers here. They found that the common outcomes of miscommunication can lead to an adverse event, with individuals commonly misunderstanding discharge instructions, leading to not following up, and missing their medications or taking them incorrectly. In short, being lost to follow up. So again, transitions of care are a critical vulnerable point that we need to pay attention to so our patients don't fall through the cracks. And that vulnerable point is also an opportunity for engagement. And that's what brings us to the concept of comprehensive transitional care in ECM. So let's go to the next slide and talk about that. So like I mentioned, in ECM, DHCS uses a slightly different term than transitions of care or straight TOC. They call it comprehensive transitional care. And it's really one of the 7 core services of the ECM benefit. The work is really similar to what we're hearing about in standard TOC work, but it's defined a little bit more in depth to focus on meeting the needs of this very complex population. And it's very tied in with the other core services of care coordination, care management, health promotion, member and family supports, and referrals to the community. It's all tied in to TOC work or comprehensive TOC work. But in short, although comprehensive transitional care speaks on patient admissions and readmissions, it's really looking at any care transition. So again, it could be someone stepping down or stepping up to a lower or higher level of care or any new care. And resource coordination is a huge component of TOC in ECM. And medication review versus reconciliation is also a key element of this core service. Now, some of your teams do have staff that are qualified to do true medication reconciliation, which is really that nursing level task. But those of you that don't have nursing level staff on your team can still perform that critical medication review. And in fact, we're actually going to be talking about medication review later in the webinar series, I think in October. So more to come on that. But a very important task in comprehensive transitional care. So let's go to the next slide. We're still on comprehensive transitional care. It's a mouthful. So this slide gives a little more detail on what some of these TOC tasks involve. They involve the development of an actual TOC plan for the member, the patient, a plan that's developed proactively and revisited, especially if a TOC event has just occurred for that individual. So these TOC activities, of course, include a reassessment of what are the members' care needs, including what new supports they need that the ECM team can coordinate, proactive anticipation of any barriers to success in that transition, which typically involve like what other formal or informal supports can we get into place for this individual. And TOC involves some tracking, paying attention to reports that alert you of an admission or a discharge, or even an ER visit. And then, of course, communicating with your team and planning from there. We've talked about medication review or reconciliation, depending on your staffing model. And then just being sure to be that glue or bridge that supports their connection to their new services. Through all this, documentation of your work is key. Updating the assessment and care plan with the member and being sure to revise those SMART goals sooner than later. Karen's going to talk a little bit about best practices for timing of that contact and communication with the member, especially post-discharge, with the messaging really being keeping that communication open with the member and connecting soon after discharge to prevent those adverse events we talked about. You know, missing appointments or misunderstanding their meds or their discharge instructions, or again, simply falling through the cracks and being lost to follow-up. So these proactive and timely tasks can truly smooth the transition for the member and are so critical, right, to the success in the ECM program. All right, so let's go to the next slide. And I'd like to quickly walk through some of the other tasks involved in comprehensive transitional care work in ECM. So these next 3 slides focus on really the activities involved with a common transition of care that I mentioned, the hospital admission process. But really, a lot of these tasks can certainly be translated to pre-work and post-work during most transitions of care. So I also want to add something. I want to comment that we're really aware that community supports providers are on this call and that you're also providing significantly supporting transitions of care. Again, many of these tasks can inform your work, you know, say as a housing navigator, providing tenancy support and sustaining services. You'll often be coordinating with that ECM team during your client's transition. So I just want to call out, we say a lot of ECM, use a lot of ECM language, but it's all tied in together. Your teams are working in coordination with the ECM teams as well. And you're also managing your own client's transition. So hopefully a lot of this, these strategies will help inform your work as well. But anyway, just looking at this slide, anticipating someone's admission to a hospital, let's say. So prepping that individual for the admission, providing as much education and planning support, making sure you have the right contact information and any new contact info from where they'll be staying, helping them anticipate what's coming. It's a really part of that planning, that education. And the pre-admission med review, getting all the meds down on paper, organizing them in advance to share with the team that will be working with the individual. And then, of course, documenting this work and communicating with your team about the plan. And really, this is all in partnership with the patient or the member in all these phases of work. Let's go to the next slide and look at the admission process. So the admission stage of a transition of care and the key tasks. So a lot of them are the same. Update that contact info, document and communicate with the team. But here's where the communicating quickly with the hospital discharge planner or social worker is key, and staying in touch in terms of the discharge plan, the where and the when, and getting that next appointment or visit scheduled before they discharge if you need to help with coordinating that. I've talked with teams who have communication plans with patients where it's a texting situation. And they'll be texting prior, during the admission, let me know when you're discharging, let's connect on Friday. And just really already have that set up that they'll be communicating during the hospitalization, and so they can connect right away. It's kind of fun to hear how different teams set up that communication plan with the patient. So let's go to the last slide on this little section. Before we hand it to Karen. And this is post-discharge work. So here's where we get into that critical importance of the timely contact right after discharge, ideally within 48 hours. And when you're making that contact, reviewing the paperwork they left with and the discharge instructions, any patient education information. And this is when you can sit down with the patient and update that care plan. You may need to update the assessment with any big changes in their diagnosis or their condition. For example, say they're ambulatory now, they can walk, and they weren't able to prior to the admission. That's an important change to document. And then depending on the individual, supporting getting to that next appointment. It may be that you're there with them or calling in. I know during COVID, when there was a lot of virtual appointments, teams strategized that three-way calling so that they could still somehow be present for that first appointment post-discharge. And then back to that care plan. So really making those new goals SMART, specific, measurable, achievable, realistic, timely, just rolls off the tongue. And I think you actually heard in a previous webinar about care planning that sometimes it's easier to flip that SMART goal on its head and start with the T, right? Start with the time bound and go backwards. I think Mark Avery called it trams because sometimes setting the date and then getting the specificity to follow really helps. And then, as you see throughout the whole TOC process, staying on top of any new contact info, documenting, and communicating with your team. All right, well, we hit a lot of what's. Let's go to the next slide. I mean, we hit the nuts and bolts of transitions of care in ECM. Really with that focus on the more commonly thought of TOC experience, which is a hospitalization. But again, there are many types of transitions of care and that are important to support. And on that note, we're going to transition to the how, and I'm going to pass the mic to my colleague, Karen Hill, to take us through the how.
Okay,
Karen?
well, thank you so much, Laura. And I want to thank you all for joining us today. The one thing I wanted to just say before we get started is part of the why of this why or the what is important, because many, and I'll talk more about this when we talk about the why at the end, is that part of our job, whether we're CS providers, whether we're ECM providers, is to really help educate the people that we're working with that may be using the emergency room or some of these systems incorrectly. So oftentimes you'll get referrals and it'll be people who've been in the emergency room, when in fact, if they were really connected to their primary care provider, they wouldn't need to go to the emergency room. So this is all they wouldn't have to have that transition. So there's all of these kind of preemptive education and training that we can do when we're doing an intake, when we're getting people enrolled into the program, we can find out how they use the system and the types of TOCs that they've had in the past. Let's go to the next slide. All right, so we're going to just take a quick poll. And first of all, does your clinic have a TOC process or workflow in place? And so Deb is going to bring up that poll for us. And number one is there's no process in place. Number two is some parts of the TOC process are in place. Number three is routine and systematic TOC processes are in place. And number four is we have a process, but it's still uncoordinated and there are big gaps. So let's see what folks say. So again, that's no process, some parts of a process, routine and systematic, and we have a process, but we're not really using it, and there's big gaps in it. Take about just maybe 50. Don't overthink it, just kind of. And Deb, when you're ready, just let us see the results. Oh, all right. So I lost you. Hang on a second. All right. So no process in place for 32%, right? So this might be some work. Some parts of a process, and some groups say we have a routine, 21%. And then some say we have a process, but we're still not really using, it's uncoordinated and there are big gaps. So hopefully after today, you will come away with some things that maybe you and your colleagues can get together and put into place. Thank you so much for that. Let's go to the next slide.
And I'll just chime in.
Sure.
Seeing that we've got at least 6 folks responding with a routine and systematic TOC process. We would love to hear just, throughout this morning's talk, any strategies in chat, what does that look like?
Yeah.
We always love to hear from folks.
Yeah, we do. And everybody else on the call wants to hear because we have, lots of folks who are still just at the beginning of this. Let's go to the next slide. All right, so we're going to have a report from the field, and that's going to be Liliana Rodriguez. But before I get Liliana on, I'm just going to kind of briefly read this lovely story. They've done a lot of work. So this is not what we can traditionally think of as a transition of care, but it's a really important one because the goal of ECM and even of CS providers is to transition people into independence and self-sufficiency so that they don't need us so much or they don't need us at all, and we can help the next client, right? So this client came to Monterey Public Health and initially was a high use individual in and out of the emergency room all of the time. It's a 41-year-old Hispanic male, married with 2 children, has a very positive support system, multiple chronic diseases, systolic heart failure, high blood pressure, high cholesterol, diabetes, end-stage renal disease, and blindness. Patient is on hemodialysis. And so there were lots and lots of problems and issues. There were financial strain, transition barriers, continued risk for a declining health and homelessness, having lots of hardship paying their rent and buying groceries and getting to medical appointments. So the client came to Monterey Public Health in March of 2022. And so now we're going to hear how Monterey Public Health, and more specifically, Liliana, was able to help this client move and transition to independence. So Liliana? I'm not seeing
Hey,
you.
everybody.
Hi, you're there. Okay.
Hi,
I can
everybody.
see
I'm
you.
here.
Okay, great.
Yeah,
And so, Lillian, I just have a couple of questions for you. And
sure.
so the first one is how did this Alliance member come to you at Monterey Public Health?
Yeah, so the client was referred by the Central Coast Alliance. It was a direct referral, and he was referred because he was a high utilizer. So it's a
Okay.
direct referral. We receive our referrals directly from the Alliance.
Okay, so he came right through the Alliance. And
Mhm.
so what were your first steps that you took to identify this client's needs? What did you guys do?
So I want to just make sure that so this was a team effort. I'm part of a team. We work in teams. It's usually an RN, a PHN, a CSA, and an LVN. So as soon as the referral comes in, we do have a process that we follow. It'll go to outreach. We have our community service aides that will try to connect with the client, just briefly go over the program and identify any needs that they might be. They get scheduled to see if they're open to services, to see one of the the lead case manager, and then they go out and they meet them.
Okay. So
Mhm.
I am really glad that you brought up that point, that this is part of a team. This
Yes.
work is going to be absolutely impossible if we try to do it all on our own. So I love
Yes.
that you brought that. So you got a referral from the Alliance, your team got together. Now you used the term a PHA. What is a PHA?
PHN, sorry.
PHN, a public health,
nurse.
okay, a public health nurse. All
Either
right.
a PHN or an RN are
Okay.
primarily the lead case managers.
All right, thank you. And so my next question for you is, what did you identify? I know that when I presented the case that he's got a lot of family support, but what other kinds of strengths did you identify in this client?
So this client actually was, the plan of care is established by the lead case manager, which is the PHN and RN, like I said, and they had identified during their comprehensive assessment that a lot of needs and a lot of barriers for this client. Some of the strengths that they found when they worked with him, and even when I work with him, was that he had a positive attitude and he was very cooperative and willing to engage. The plan of care is always geared towards, the patient being involved and actively participating and engaging with our team.
That's really, really important. Somebody has to agree and has to participate. And
Yes.
we've heard often, a lot of times, that that's really sometimes hard to get folks to really cooperate with you. So
Yes.
that's really good. That's absolutely a strength. And the fact that he had strong familial support is another big plus. Okay.
Yes.
So now tell me, how did you and your entire team really assist him? What exactly did you do?
Lots of care coordination, phone calls, making sure that we continue to work with him closely, making referrals, making sure that he was following through. We assisted him with placing sometimes even three-way callings, and just care coordination, lots of care coordination, calling social workers, working with other people that were assisting him already, but nothing was everything was very, very slow, a slow process. So just being able.
So when, I don't mean to cut you off, but when you talk about sort of that care coordination, what specific services did he really need that he couldn't get on his own? Had he been trying to make these calls? What was happening?
He was. So he did. He had a social worker at the clinic site. He also had with the Department of Social and Employment Services, he had another social worker. He was already notified on the benefit for transportation, but had some issues there, barriers with that. Basically just calling them, working with him, making three-way calls and ensuring, facilitating basically the process and getting him those resources.
Okay. And what were the problems with his transportation?
So transportation, when he came to us, he had mentioned that he was denied transportation from the Alliance because they had a working vehicle in the home. It kind of didn't make sense to me a little bit. So we went ahead and I went ahead and let the team leader know what was going on. And she guided me to call over to the Central Coast Alliance and get a hold of one of the representatives. So we did that, and he was actually screened and approved and was able to get connected for transportation, which was primarily one of the main reasons why he was failing to go to his medical appointments and utilizing the hospital.
Okay, so see, that's great. So advocacy is a big part of it. He might not have known to get in touch with them. That's actually really, really great. So now this client is now independent and no longer an ECM client, but can you tell me, how did you prepare him for this transition? What were their steps that you had to do to get him ready? And what are you it's like two questions then. So what were the steps to get him ready for transition? And what are you doing, if anything, to support that he continues to be successful outside of the ECM program?
Yeah, so there was, like I mentioned, working closely with him, providing education, ensuring that he was understanding the steps to take for ordering medications or understanding even his medications, then making sure he knew his the instructions well and how to get connected to the providers if need be. Lots of education was provided to him, as well as encouragement. So a month before, I think it was the 5th month of him being enrolled, our team always does team huddles, and we discuss our cases to make sure that everything is running smoothly. Linda, if you want to add anything, if you're on the call. Linda and Miguel are the staff members that I work closely with, but just preparing him and letting them know, we're coming up closely to your recertification period. How do you feel about being able to manage, your health and your appointments and everything on your own? And he was very, very positive about being able to pretty much take control and manage his self-care on his own.
Well, this is really, really great. And he has not been back to the emergency room since, right?
No, he hasn't been in the emergency room for about a year.
Oh, wow. This is great. This is really great to hear. I mean, we don't often hear these kinds of stories, but it does. And you should pat yourself on the back, the entire team, because that's really the goal is to keep people self-sufficient and keep them moving independently. Miguel, did you want to add something? I see you came on camera.
Yeah, I can add something if it's okay.
Okay, well, you got both.
There you go.
Then. Okay.
Wait, of course, Linda, go first.
Okay, Lily pretty much did a lot of the work on this client on her own with our collaboration. But I think it's very difficult for a client with end-stage renal disease going to dialysis. And his dialysis appointments were 6 o'clock in the morning, 3 days a week. And to be denied, not proficiently denied, but not supported on transportation. And they had a car, but his wife was the one who would have to get up in the morning. We would say 5, get him ready, get him to dialysis. That's a very big challenge.
Yes.
To have end-stage renal disease and be in dialysis at 6 a.m. 3 days a week, that's a big challenge, because the biggest challenge is having kidney failure. The second one is wondering how long you're going to last with kidney failure.
Right.
And then to be in dialysis 3 days a week, 6 a.m. in the morning, and not have guaranteed transportation. Right. I think they were originally not supported because they had a car. But Lily, correct me if I'm wrong, I don't think the car was very reliable, and I think it's a big strain on the wife to be the one having to take him in 3 days a week. And he was proficient in making it, getting there and staying on track.
And then they also, I want to add that they have 2 small children, school-age children in the home. So that was definitely a huge barrier getting to those appointments. He would just prioritize and have the girls go to school, have mom drive girls to school, and then miss the medical appointments that were important. So I'm glad that we were able to connect.
Well, I think this is a great exemplar, and I want to thank you all. Perfect example of teamwork and of advocacy and meeting the patient where they were. and moving them forward. So thank you so much. And I appreciate that. And people want to have questions or any of that, please just jump in. I'm just really proud of you. This is one of my teams, and I just think it's really great. So this is excellent, excellent work. Let's go to the next slide. Thank you so much. All right. So challenges, we're going to talk now about some challenges with supporting this work. People often have difficulty with role clarity, and I think that it was really great. Lily started talking right at the very beginning that this is a team effort and everybody sort of knows what their role is. That's really, really important. Who's going to reach out to the patient? Who's going to get that consent form? Who's going to connect with the alliance? Having those huddles, there's another term that you use, talking about those things and communicating. A lot of these problems happen because of communication, that one department wasn't connecting and understanding, and the communication wasn't clear. This individual seems like had lots of support to social workers and still needed to have somebody else come in and help clarify all of that. Patients trying to do all this on their own, but really can't. Making sure that they're speaking the same language, like sort of hospital talk and transition talk and all of that the same, not necessarily whether language, when I say Spanish or English or something else, I just mean healthcare talk, so that we understand. And it sounds like through your advocacy, you were able to make that really clear. And then there was that big, deep foundation of patient education, aligning what the patient needs, making sure that they understood their follow-up, making sure, can you get your medications? How do you get them? When do you call for them? Some of our clients really don't have the support network that this individual had. They might be unhoused. They might be using the emergency room as their primary care provider. And this is a point where we can come in and help educate them so that they're not using services inappropriately for what we often term as ambulatory care sensitive conditions that if they were to see their primary care provider and connect with them on a regular basis, that they wouldn't need to go to the emergency room or urgent care. And then being accountable, right? That they're accountable to themselves and to their families, and actually and the providers are accountable as well, responsible, ensuring that it's coordinated between all the settings, things are documented so that when somebody comes behind you, they know what needs to be done. And to also think about, we still are certainly in this, our healthcare pandemic and different phases of it, and to know what's really going on. This client was particularly vulnerable. Here he's got end-stage renal disease and immune issues for sure. We're in this COVID environment. He needs to have this dialysis. He's living in a home with small children. We all need to advocate around him. So let's go to the next slide. Those are the challenges of ECM and CS providers. So just quickly in chat, tell me, what are some of the issues that you have identified in your that have come up for you in the pandemic around transitions of care, services, and issues? Just quickly tell me that. What kinds of challenges have you had? We know transportation is often a big one.
And we've all sort of adapted to this work during the pandemic. And what do you kind of anticipate you're going to continue to do that's actually working well for you? So that's the second question, like what strategy do you think you're going to continue to use?
Yeah, to use. I will say that as you guys are thinking about that, what I'm finding for a lot of folks is there's just this pent up, backup, long time getting appointments. Sometimes clients want to get an appointment, but they can't get an appointment for 90 days or, 45 days because the primary care folks and specialty folks too, are now trying to get to those folks that they couldn't see during the pandemic. So that's really hard. Let's go to the next slide. If something comes up, go ahead.
One comment,
I don't see
Karen,
anything. I don't see it online.
from Tracy, telehealth, and I agree. I think we're realizing telehealth actually is extremely effective, and you don't always have to be in person. It really has improved access to care.
Yeah.
Like what Karen's talking about. Yes, a lot of telehealth.
I see that's coming up now. I see
Wonderful.
telehealth is coming up. Yes, for sure.
So
yeah.
yay for that. We figured
Yep.
that out.
And that works really great for people who know how to use that and access it. But we still have that cadre of people who really don't know how to use it. So I think that one barrier, Miguel says one barrier you notice is patients not knowing where to start, where they left off in their care. Right. It's been so long that they don't even know what they should deal with. That's actually really true. That's really true.
And that's why this is such an important conversation.
So it is. And we're going to have more of this conversation. Let's go to the next slide. Okay. So here are some of the best practices. One practice, and it's certainly in here somewhere, is whenever you engage with a patient, you need to be finding out right from the very beginning, getting that medical information, finding out who the important people are, getting those numbers, being able to contact them, and then also just finding out how they use healthcare in general. Are they somebody who makes appointments and keeps them? Are they somebody who sort of has the, if it's not broken, I don't fix it mentality, where you can kind of start educating folks right from the very beginning and follow up with people. You know, if a patient within 2 to 3 business days, if they go to the emergency room, if they go to the ER, when you talk to them in that intake call, let them know that if they ever are in the emergency room, if there ever is an urgent care, that they need to contact you. Make sure that your phone number is in, and there, if it's a text system, how you are going to communicate with them so that you can intervene earlier. There are lots of things. I think Laura talked about it in her section, where these transitions are vulnerable. That's when people fall through the cracks. They don't get their discharge medications, or they don't take them correctly. And what happens? They end up back in the emergency room. Medication review, making sure that the medications that they may have stopped while they were in the hospital and they still need to be on are restarted, making sure that there's not interactions. If there's a follow-up appointment, that appointment is made. All of those are best practices. Communication, follow up is part of, is really core to this work. Let's go to the next slide.
And I'll just add on, Karen, you know, when we talk about, these are the transitions of care, these vulnerable periods, and I also added on, it's also an opportunity. The individual's vulnerable. They're at a weak point. They're in an acute phase of their illness, and so they may not be absorbing all that information. They're not, so it's supporting them through that time when they're especially vulnerable too, and just not able to absorb all of those instructions themselves.
You know, you're right, Laura. And 9 times out of the 10, they don't absorb it at all. It's real fast. Somebody's telling them real quickly and trying to get them discharged and get to the other patient. But the other thing, sometimes that's an opportunity that transitions to care, because the patient is in, a client is in the hospital or in whatever situation, they've just been diagnosed with a new something or other. You might have been trying to get them engaged before, but they weren't. And now they know they really need help. And that's an opportunity for you to step in at that point. So look at it. It can be a double-edged opportunity. So yeah, let's go to the next slide. All right. So the why. So I think we are clear about this is the why, that we need transitions care. We know that oftentimes folks end up right back in the hospital because They didn't get their pain medicine. They didn't get the antibiotics. They didn't take them correctly. There wasn't the right support at home. Perhaps the home care agency that was supposed to be called, or the DME stuff that was supposed to come to the home, didn't come home. That follow-up appointment wasn't made. It's essential for part of this work. Sometimes folks are losing their housing because, or they're, you know, they have forms that need to be completed or rent that should be paid. All of these are reasons why transitions of care and supporting and educating patients right from the beginning that some of these things do happen. Let's go to the next slide.
And we have some really good comments in here, Karen.
I know they're great. You want to talk
Yeah.
about them keeping up with good lines of communication within the care team? Absolutely. Communication, helping the PT, patient, is that patient or PT? By prompting them to document upcoming appointments. The patient, to document their appointments. COVID can cause other health problems that are overlooked.
Yeah.
A client went to the ED with chest pain, positive for COVID. Absolutely, there's so many reasons. And this is just a great opportunity. But I want you to look at this, this picture we have here. And this is a perfect exemplar. I love this slide of what's wrong with this picture. This is a perfect why we have ECM. Great tips. Yes, Sadie. Thank you for adding that in there. What's wrong with this? You see all of these places here, the EMS, the home health, community supports, long-term care. You know, we've got the client in the center here. Part of this is so confusing and why your role is so essential. Yes, Miguel, it's overwhelming. Can you imagine getting a call from the long-term care folks? I mean, even in the Monterey case, where there were 2 social workers, having those people call, and the pharmacy calling you, and the doctor's office, and the ECM, and all of these. And here's the poor patient trying to manage all of this. It's really not the way it's supposed to go. Let's look at the next slide. ECM is really built so that you and the primary care and the CS group are all talking and sort of coordinating all of this work, and one message is coming to the client. One message, who might not be, the client may not be so medically sophisticated. They might be struggling. Most of the times, I know who your clients are. They're struggling with mental health problems, substance use disorder, physical problems, managing life, trying to find a place to live, all of these things. It absolutely can be overwhelming. But if they have one person to call that's going to help coordinate all of these other entities, who they speak the language of pharmacy and home health and EMS and all of that, it simplifies the process and coordinates it for the client. Let's go to the next slide. So when we look at the 5 core values of this work, it's med management. You know, does the client know their medicines? Do they have the medicines? Can they afford them? Do they know how to take them? How are they, how are they managing them? Are they having side effects? All of that. Communication with all of the players, including primary care. It's essential for you to know who the primary care provider is. And if there isn't one, to help them to get connected and help tell that story to the people that we serve, our clients, and coordinated timely follow-up. It's not helpful to find out 2 to 3 to 4 weeks later where you call your client or the member if they were in the emergency room. A lot of times they don't remember. So making sure that they know anytime they have an interaction with, if it's emergency room, behavioral health, the detox center, what moving even from one place to another, The other thing I want to talk to you about too, that's a transition. Sometimes things happen, social things happen in folks' lives that can derail their health care and derail their mental health. Maybe a divorce, maybe a big breakup, a big problem with a child or something like that can really get people who've been on a stable course, they can be unstabilized. So having those communication with them, educating the clients about this stuff and the things that can trigger them to not take their medications, to not follow up, particularly if there's an issue with a family situation, somebody getting sick, and so they have to maybe jump in and help care for other members. It can derail their own SMART goals and their own goals for themselves. And that's where the transition of care model really comes in. You have to consider all of these aspects. Let's go to the next slide. So in summary, transitions are particularly vulnerable. We've talked about that, all of these places, and this really all helps to support our why. Missed appointments, poor communication. People, I've shaken my head, yes, I understand. And when the person walks out, I'm thinking, now, what did they say? I have to get my papers out myself and read them. You know, so these are all, we often don't connect if we're stressed about something. Develop consistent strategies to avoid admissions and readmissions. The more times folks connect with emergency rooms and are in the hospital, really the more vulnerable they are to other infections and other things like that. So it's best if people don't need to interact with the system outside of their primary care, that they don't, right? Educate, plan, help people think ahead. If it's a planned surgery, let's try to troubleshoot all of the things that might derail them and link them to the things that they need, and focus on building those excellent relationships so that they can know that if they call you or you're somebody on your team, that you are going to follow up. Remember who our clients are, that they've had broken promises many, many times, that the case manager that they had is now got another job and there's nobody else that is going to follow up. So, and having a comprehensive plan so whoever does follow up knows what you were working on. This speaks to what Miguel was saying is, you know, if we have a good updated care plan, then we can help the client remember where they were in their care. And try to attend that first TOC appointment if you can, whatever the appointment is. That way you can hear it yourself, because sometimes our clients can't always translate back what they've heard. It can be overwhelming or they don't really understand. And make sure that the client has a copy of the plan so that they later can read it at their leisure and find out what's going. Make sure it's in their language and in a way that they can understand, and you can go over it with them and use it as a reference point. Let's go to the next slide. Okay.
Miguel's comment, because he sums it up so beautifully, that it's really, this TOC model is meant to focus and streamline the process of managing the patient's care. Like
it is.
Well said.
That's it. That's
it in a nutshell.
That's the why. That's absolutely the why. Couldn't have said it better, and I'm glad you saw that. Do we have it? We have a little bit of time now. Do we have any questions or comments?
I wanted to add one thing, Karen, while we're waiting for folks to chat in. There's another team I've worked with in a different county that has a TOC huddle. So that's kind of their process. So that's not super complex, but they know that they have a regular meeting where that's what they're talking about. They're identifying individuals who may have gone into the ER and come out, or the hospital, and they're planning as a team for who goes out, who does what, and of course updating their, you know, any documentation. And I see, Miguel, your hand is up. Did you unmute?
Yeah, no, it was actually a piggyback, and it was what I was trying to say with part of me, Liliana, and Linda's process is we actually do a weekly debriefing on what's up with our patients, our course load, so we can not only manage and see what our tasks of the weeks are, but also figure out upcoming things for certain patients And a lot of times, if it's like a sudden thing that'll come up, the good thing about it is like, say, hey, Miguel, go check on this person when their next PCP visit's going to be. I'll have the context. I'll have that idea of what to do. As I told my supervisor, April, it's like practicing basketball where we're just doing drills, passing the ball back and forth.
Exactly.
Is that United Care, it would be like 3 people working together as one instead of 3 separate people like lost in space trying to like, where were they at? What were you? Did you talk to them? No, it's more like, oh yeah, you spoke to them. Good. Okay, good. Follow up on that, will you, Miguel? Yeah, sure. Thank you.
I think that's great. And you know what, Tracy said something about broken promises and feeling abandoned. But the other thing, thank you for that. That's a great comment. The other thing that good communication and team supporting each other, that team-based approach does, is it reduces your own stress and it reduces burnout. That's why transitions of care and using those core models, those core components will support your work. I can't say it enough. This work is hard, it's difficult, and it can get very messy. And so we all have to watch each other's back because anything can happen. Things happen in our own lives, right? So we need to be able to pick up and to do those drills in your, so that we can catch the ball for the next person. Sadie says, suggesting reducing care team stress, breakout rooms and huddles. Yeah, that's a really great. So I think that we've got a poll coming up next, don't we? Let's go to the next slide. Yeah.
We have what's coming up next.
Yeah, which is going to be trauma-informed care, which supports this transitions of care model. And that will be probably Laura and I doing that together, or me doing that. I'm
I'll help as I can, but Karen is the trauma-informed care guru.
And so, and I'll show you how
great.
that supports this whole model here. And that's going to be September 22nd, and same time, same channel. And now right in the link here is our Survey Monkey. You guys, as always, are just such a delight to work with. I'm just so thrilled that I've am on this project with you. I learn from you. I learn from you every time we meet. So, and my team, thank you so much, Liliana. You were great, a great presentation, and Deb Peartree, perfect in the background, and Laura as always.
And let's just jump to the next slide. Yes, I did put in the link to the Survey Monkey, which you are probably familiar with. We actually added some questions onto that Survey Monkey, as I had mentioned earlier, really around some suggestions around the length of the learning sessions. We're hearing some feedback that possibly we might need to extend them just again so we can have that breakout, quality breakout room session, kind of like what Sadie was suggesting. And also, we wanted to check in around sharing a roster of providers. We've been, as being coaches, we are hearing from our teams that they would love to have contact information of the other teams that they're talking to on the webinars and in the learning sessions. So please let us know if you're okay with that, and then we'll send out a nice roster so that people can connect outside of these webinars and learning sessions. And as Karen said, we thank you so much for your participation today. And we love seeing you these every other Thursdays, essentially, and having your great information and hearing your own wisdom in terms of what your work is. And again, thanks to Monterey Public Health. And we look forward to seeing you on the next webinar. And also, for those of you that are being coached, we look forward to seeing you on those calls as well.
That's right.
We'll go ahead and leave this open for a little longer and then say goodbye. Thank you, everybody.